Just think of it this way. The bigger the prosthetic ball that we put in for your hip replacement, the bigger the artificial ball, the less likely you are to dislocate. You with me? More range of motion in your hip with the bigger ball. The smaller your socket, the smaller the ball I can use. So if you have a small socket and I have to put a small ball in and you have a high preoperative range of motion, you're at a higher chance of dislocating. Does all that make sense? Okay? So I started to say to myself, well, geez, if I'm publishing a paper on this and presenting it, maybe I ought to do something about it and heed my own advice. And so, although I didn't have a problem with dislocating the posterior approach hips, I was here in Hickory in practice for just over a year. What do you think, Heath? Just over a year? And I said to Heath, I said, it's time for me to come in the front door. So I spent the better part of 10 months going to courses, doing cadaver work, researching this, learning about different techniques, trying out different instruments. We brought cadavers into the town. We set up the whole OR team. We did surgeries in the hospital with cadavers and ran through this. I traveled to Memphis, Tennessee. We went to a course in Charlotte. I scrubbed in with surgeons that have done a lot of these. Spent 10 months before I did my first one of these, figuring out how to do it. So I made this commitment based upon science, based upon studies, based upon my own experience. And it's been a great thing for my patients. To date, we've done over 250 of them, and we haven't had a dislocation yet. Okay, not that we have a lot from the posterior approach, but the thing I love about this approach, coming back, I'm setting all that up to tell you this last part. The thing I love about this anterior approach hip, this ASI hip, is you don't have a hip precaution in the world. How many people in here have a hip replacement in already? And you had traditional approach hips? And you have the limitations, right? You can't bend your hip this way, you can't turn this way, you can't do certain things.
I guess I could.
Yeah, don't. Please don't. But the therapists, Amy's over here, she'll tell you about this. There's some more therapists in the back there. But they're going to talk to you about how you move when you have a traditional approach hip. You shouldn't bend over at the waist. If I had a right hip replacement and I need to pick something up off the floor from a posterior approach hip, they're going to tell you to really bring your leg back like this and make this big, cumbersome effort to go down and scoop something up. Or you get that grabber. You get the grabber. You can't bend down. You got the little plastic grabber you buy at the dollar store. So there are limitations to your hip motion, your hip activity, your hip replacement because of the instability, if you will, or potential instability, better phrased, of the traditional approach hip. Well, guess what, folks? If you're a candidate for the anterior hip, notice I say if you're a candidate for the anterior approach hip, then you don't have to worry about that. The only thing I tell you I don't want you doing is I don't want you running. Unless someone's chasing you with a gun or a knife, a different story. Then you can run like the wind. But I don't, that's it. You just go about your life. You don't have to think about it. We don't limit you on what you do. It's very, very weighs on people's minds, I guess is the best way to say it. There's actually a paper written about that and how patients really liked traditional, they liked not having the hip precaution. So I love that part of this. You've got a lower dislocation potential, and I don't even have to limit your hip positioning. So I think for select groups of patients, this is a very good thing.
I got a question.
Mm-hmm.
So if your hip comes out, you have to go back in there and have surgery again?
Most of the time we can sedate you, get your muscles relaxed enough, we can pull it in without a surgery, most of the time.
So I bet it hurts, doesn't it?
It hurts when it's out, you feel a lot better when it's in. But then you're wearing a brace for 8 or 10 weeks. And so it's not something you want to happen, but a lot of times you don't have to have a surgery. A lot of times we're able to pull it back in, brace you, the hip will scar back in, and we'll remind you of your hip precautions and things of that nature. The other benefits to this surgery is that I can more easily assess your leg length. I use x-ray during the procedure right there. So the patient's set up, that's a real live x-ray machine that gets sterilely prepped into the field. So I can look at where I'm putting the cup, I can look at the stem going in, I can check your leg lengths in the operating room and help minimize any potential inequalities in that or bad positioning of the components. I do enough hip replacements that we don't really ever have to change the component position, but I take an x-ray in the operating room, a traditional x-ray, not with that machine, of every hip I do. Every posterior approach hip that I do, I take an x-ray in the operating room because that's the time I can fix something. It's not what good does it do me to do an x-ray of your hip once I've closed your wound and you're in the recovery room. If something needs to be changed, the time to change is before we close your wound. So everybody gets some form of an x-ray in my hands because I think that's good medicine. But But here's everything draped out. This little hook here is a special device that you need to do this surgery. It's attached to a power elevator. That device there, sterilely dressed into the field, and that helps us pull the femur bone up when we're trying to do your surgery. You can see here an intraoperative x-ray of this particular patient. That's the reamer that we use to clean out all the arthritis and cartilage. And that's a cup, that's the final implant position right there. Heath's loving that, aren't you, Heath? That's not his cup. This is how we use that table. We move the leg around, the operative leg, we bring it down and over, and we're trying to deliver your thigh bone up so that we can put the stem in. Trying not to gross you out, I try not to show too much blood or tissue. But that's that hook pulling the thigh bone up. There's the final implant. That's the metal ball. And the stem in there. There's the total incision right there, not too long. There's our leg length, showing that we have pretty equal leg lengths in the operating room. There's our final x-ray. So that's kind of the benefits in a quick, brief synopsis of what we get from that surgery. We don't cut muscle. Theoretically, there's less pain. Theoretically, there's an improved recovery time. I can't prove that yet. I don't think any science has proven that, but I do think that patients that I have a retired physician in this town that played tennis 3 weeks to the day of an anterior hip surgery. I didn't recommend it, but he did. He won money too, he told me. So he did pretty well. But people, I think part of it's patient selection. I tend to track towards healthier, younger people with this surgery. So they were bound to do well with either procedure. But there's no science to show this makes you recover quicker. The reason I like this surgery, first and foremost, and I'll reiterate it again, is that you don't have the hip precautions and you have a lower dislocation potential. I think that's the take-home point from the anterior hip. We're going in between the muscles and all that, and maybe that makes you recover faster. I personally think you recover as fast as your head allows you. You recover as fast as you can convince yourself to trust your new hip or knee, okay? And that's patient dependent.
So when bare pressure drops, do you feel a lot of ache with that piece of metal in your body?
Some people say that, but then again, some people say that goes away because they felt that with their arthritis, but we've cured your arthritis. Again, there's no science to that. There's really not any proven science to that. I can't really say yes or no. Some say yes, some say no. What I can tell you is pretty much 100% of people, particularly with hip replacement, will tell you that their preoperative pain is gone. And where's my therapists in the room here that work with? There you are. So what do they tell you the postoperative day one after a hip replacement?
Feels different.
Yep.
Feels better.
Feels better. And that's the day after surgery. So it's a powerful surgery in that sense. I won't pretend to tell you that a total knee is going to tell you the same answer.
Would that be the same with the knee? That's what I
No, sir.
didn't think so.
No. Maybe with a partial knee. Maybe with a partial knee. There's definitely a difference between a partial knee recovery and the early going and total knee. So remember, I've told you I don't know that I can prove that there's a difference between the ASI hip and a traditional hip in terms of the early recovery. But segueing into the last part of this talk, there is a difference between the recovery and the early going of a partial knee and a total knee. There's far less pain and I think a far quicker recovery with the partial knee. End game, you get to the same point. Okay, so I did this ASI hip because I studied this. I thought about this. I thought, gosh, there's nobody around here doing this. The community needs this. This is better for the patients on a lot of levels, as I've outlined. And we've done over 250 now in the past, I guess, 28 months or so. Okay, we'll kind of talk about a little bit about total knee and partial knee. You can do total knees through smaller incisions and do a good job. They don't have to be this big anymore. My average total knee incision is probably that big with your knee straight. So it doesn't need to be this big if it's this big. Partial knee incisions are about this big with your knee straight. Total knees are about this big with your knee straight. We'll focus a little bit on partial knee today. Total knee is a very common procedure. It's a wonderful surgery. Partial knee and total knee will get you to the same endpoint, and that is a knee that feels better if I do my job correctly and you earn your outcome with therapy on the end game. But you can see here, tell me which one's going to hurt more. Right. Just makes sense, right? Just makes sense. Whereas with the hip replacements, no matter what approach I use, it's the same implant. This is clearly a different implant. Now this surgery here what you don't see in this model is there's a ligament that runs right here called the anterior cruciate ligament. That's what all the athletes tear, okay? That ligament has to be normal to be a candidate for a partial knee. The cartilage on this part of the knee has to be normal. It's debatable whether the cartilage up there has to be normal. We won't go into that. That's a 2-hour independent discussion. This, it doesn't matter what the cartilage looks like, because remember that capping cartilage I talked about? I'm cutting off a thickness of capping cartilage that's 9 millimeters thick, effectively, and guess how thick that implant is? 9 millimeters. I'm putting a new cap on. Make sense? I'm cutting off a certain amount of bone here, and I'm replacing that bone with this. This is a metal tray, and that's a piece of plastic that snaps in, a high-end piece of plastic called polyethylene, same in your hip. This clips it in. The metal tray and the metal capping part on the thigh bone there are cemented in place. So again,
What alloys are the metal?
what's that?
What alloy is
Yeah,
the
so
metal?
that's a good question. I think I just knocked this. Hold on here. I think I just knocked this off. I'm going to throw it in my pocket and it's fine. Most of the alloys tend to be cobalt chrome. If people have a true and real nickel allergy, there's an implant on the market that's made of a component. The thigh bone component is made of a material called oxinium, which really has no true nickel content, and their tibial tray is made of titanium, which is also virtually nickel-free in that manner.
How dense is the poly?
The density of the poly, well, biomechanically, it's rock solid, it's dense, it's an ultra-high molecular weight polyethylene.
Okay.
I can talk to you more about that later. I'll get you Steve Kurtz's name, and we'll let you have fun with him. But this poly is not soft, in other words. It's a very rigid, firm.
UHMW is pretty,
Yeah,
pretty high.
it's pretty high density, absolutely. Very, very low. We've got, we need it to be that way biomechanically. It can be a little bit softer in the hip, if you will, and we treat it differently in the hip because the mechanical forces, just to get off topic, we're looking at different forces in the hip, and so we can cross-link the hip polyethylene more safely. If you're following me on the biomechanical, you're going to get better wear but weaker poly. Make sense? Partial knee incision, total knee incision. Again, incisions heal side to side, so I don't think this is an important component of the recovery. What's an important difference between the partial and the total is the amount of work that it's involved. This is just a small part of your knee that's being dealt with here. So what are the benefits of a partial knee? I think you can safely say that a partial knee will have decreased early pain, a decreased hospital stay, it's usually overnight. You'll have a decreased complication rate, your risk of infection, wound healing problem, blood clot, blood transfusion. Okay, they're about half the risk of a total knee. Now, let's put that in perspective. The national average for infection and total knee replacements is about 1.5% nationwide. Now we're looking at less than a 1% infection rate with partial knee. The risk of complication of blood clots, somewhere 1.5%, 2%. Again, half. The other thing I like to think of is it's a game of twos with partial knees. Okay? It's a game of twos. We're getting half the complication rate and twice as quick a recovery, basically. If you were on a walker for 2 weeks with a total knee, you might be on a walker a week with a partial. If it was going to be 6 weeks till you went back to work, it's probably going to be 3 or 4 weeks with a partial. Certain jobs specific. You can't be a laborer and go back that quickly, but I want you to think of it that way. Half the complication rate, twice the recovery is a simple way to think of it. But in the end game, I want you to also understand it's not a half a knee, and it's not a half a surgery. Done correctly, the partial knee replacement is every bit as effective a surgery as a total knee replacement, if not, quite frankly, a better surgery. Okay? There's this and I'll let you in on a little secret here on the next slide, but you're going to hear this. If you elect to have a partial knee, and I'll spend time discussing this with you, I believe in the partial knee immensely. Okay? It is a great surgery for the right candidate again. It's not for everybody. But in the same token, I'm going to spend a lot of time talking to you about the myths that you're going to hear. Because if you're going to make a major decision to have a partial knee, you need to be appropriately educated. And despite that education and despite my belief in the partial knee, I'm not there to sell it. I'm there to give you information. I still have plenty of people that choose to have a total. I would choose to have a partial if I was a candidate for it over a total. I don't take a dime, by the way, for saying that. I'm not on any company's payroll, full disclosure. I just believe it's the right surgery for the right candidate because I think it feels better. We leave all the ligaments alone. We sacrifice ligaments in a total knee. Your brain and your knee are linked better if we leave that anterior cruciate ligament in place. The plastic moves and slides a little bit. That knee feels less mechanical. The partial knee feels less mechanical. So there's some benefits in that front. But
Do x-rays determine whether a partial knee or a total knee is?
absolutely, absolutely, with about 98% certainty. Every partial, great question, every partial knee patient is consented for a total knee. Last week we were doing a partial knee and I converted it in the operating room to a total knee. We got in there and the cartilage over on this side of the knee, despite the x-rays looking like this lady was a perfect candidate for a partial knee, there was a big old honking hole in the cartilage right there, right in the weight-bearing part of that. So the x-ray can't tell us that. So 98% of the time the x-ray is right. But that lady, we instantly converted her to a total knee because I don't want to leave arthritis in the knee. Okay, coming back to that point, you're going to hear people tell you, you will need a new knee. It's not a good surgery. You're going to have it converted to a total knee. Well, that's not true. There is less than a 1.2% rate of need to convert this surgery to a total knee because of progressive arthritis over here, if the surgery is done right. Does that make sense? Basically, it's a non-issue. And that's data out of Sweden by a guy named Ulf Svard. That's at nearly 20-year follow-up now, folks. This is really good science. 20-year follow-up. The folks in Britain, in Oxford, England, this particular device here is called the Oxford Mobile Bearing Partial Knee. There's other types of knee replacements out there. But the data specific to this implant, which is the one I choose to use, because I was trained on it, not because I get money for it, okay? But this implant here has almost 30 years worth of data out of Oxford, England. Now, I'll take that with a grain of salt because those are the guys that designed it and they're incentivized to market it worldwide. But now there's plenty of good data at other centers that are not incentivized financially for that implant to do well that are supporting the Oxford data. So we've got 15, 20, and sometimes 25 years worth of data on this. And it's showing that it's every bit as durable, if not more durable, than a total knee. Patient satisfaction scores are higher with a partial knee than a total knee. And I can tell you, in the numerous patients that I've had my senior retired partner, Dr. Winfield, had done a total knee on, that I've had conversations with and had them have a partial knee, they are happy with their total knee, but they are more happy with their partial knee. They like their partial knee better, routinely. Okay, so it's a good surgery. It's not a half a knee. It's not a knee that's a staging procedure. A correctly chosen patient with a surgeon that does the procedure appropriately, that implant will last every bit as long or longer than a total knee. Okay, so why is it that doctors will tell you that the partial knee is not a good surgery? Why is it? I'm going to let you in on a little secret tonight. They're technically harder to perform. Period. It's a harder surgery. It requires a different skill set. A general orthopedic surgeon can do a total knee and with modern day instrumentation do a good job in 95 to 97% of the time for a standard bow leg deformity, get you a good knee replacement without even thinking, because the instrumentation and sizes and options we have technology-wise are so good. I'm more worried about the 3% to 5% of the time that doesn't work. That's why I do traditional, what we call gap balancing techniques. I don't depend on the instrumentation. I do old school techniques like they did. I use the guides, but I do the old school techniques that they did to balance the gaps before they had all this reproducible data or reproducible guides. Okay? So a total knee is an easier surgery, believe it or not, than a partial knee. So why don't these guys do these partial knees? Because it's harder. And that's the secret, and that reason a lot of doctors poo-poo partial knees. Because there's plenty of data, partial knee, implant, independent, fixed bearing where the plastic locks in on the partial knee, mobile bearing like that device where the plastic slides and glides. Great data at 15 plus years that it's every bit as good or better than a total knee. So why don't they do it? That's the reason. They weren't trained on it, they don't feel comfortable with it, and they're just going to tell you it's not a good surgery because they don't do it, and quite frankly, I don't blame them. They want your business. They want to be your doctor. They're not going to tell you, oh, I tell you what, go across town and see my competitor. He does partial knee. You'll love him. And they're not going to do that. They want you, but here's the thing. They're not doing you any harm by not sending you for a partial knee or doing a partial knee, because a total knee is a great surgery and it's going to fix your problem. I do more total knees than I do partials. Probably only 20% of people I see I do partial knees on. Still doing 80% of the people with totals. So don't misunderstand me there that that's a better surgery. It's just the right surgery for certain people. Yes?
Can you go back to higher levels of activity with a partial knee?
I don't let people do anything really different. I don't want you running. I do think you can probably do a little bit more kneeling, probably have a little bit better ability to do deeper flexion activities with a partial. That's not scientifically proven. But I think the partial knee, again, there's probably a selection bias to a little bit more active, younger patient population. So I think they end up doing more, but that may be more just the patient and not necessarily the surgery or the implant.
Does that just eliminate sports altogether then?
No, not at all.
Tennis and-
Adult, I think I don't eliminate tennis. I think singles
Running
tip.
tennis, though.
Well, I mean running. Let me clarify. Running for conditioning.
Oh,
Okay.
okay.
Most people who have hip and knee replacements will do very well in a doubles tennis match. They will not do very well in a singles tennis match anymore. Of course, if you've got a terribly arthritic hip and knee, it's been a long time most likely since you played singles tennis at a very high level anyway. And if you are still playing singles tennis at a high level, then you don't need a hip or a knee replaced. Right? Okay, so we've got that consideration. Doubles tennis, golf. I have a patient I did an anterior hip on who 6 weeks after the surgery hiked Mount Mitchell and is leaving on Monday to go to France to the Pyrenees, and he is taking his bike with him, and he is recreating stages of the Tour de France 3 months out from his anterior hip.
How old is he?
He's 61.
Oh,
He's a freak of nature.
He's young.
He's just a freak. He's like this giant ability. He has this giant ability to just consume oxygen. He's just an aerobe. I don't understand it. I look at him, he walks down the hall, and I'm out of breath. I mean, this guy can just consume oxygen and do these kinds of activities. Most of us can't do that.
Is
Yes.
there any difference in activity with a full replacement and a partial replacement as far as
Yeah.
activities and running?
Same question, effectively. The answer is no. I don't limit the activity with a total or a partial any differently. I just don't want you to do a lot of repetitive pounding and running. Now, what I will tell you is the partial knee feels more natural because two things, I believe. Number one is the ligament, the main ligament in the knee, the anterior cruciate ligament, which runs right here. It's still there. And every total knee replacement, pretty much every total knee replacement except one idea that didn't really work, sacrifices that ligament. So think of a total knee, pretty much that's gone, that ligament. Partial knee, it has to be there or you're not a candidate for the partial knee, any type of partial knee. Okay? So that ligament, the anterior cruciate ligament, the ACL, that ligament has a link to your brain, if we will. It's called proprioception. And by virtue of leaving that ligament in your knee, you feel more natural. No doubt about it. And also, the second thing is that piece of plastic here slides back and forth on that tray. It slides in and out, back and forth. It moves, it glides. Whereas here, here this plastic's locked in place. And every other partial knee replacement, the plastic locks in place to the tray. So again, this particular surgery is a little bit harder because you have to balance things just so that piece of plastic doesn't spit out since it's not locked in. So it's a little bit technically more demanding, a little bit more artsy, if you will.
Is that run around knee or go around knee? Is that the concept?
Oh, well, the go-around knee is a knee that's been FDA approved for nearly 10 years. Well, 10 years, you think? 8 years? 8. Okay, it's called the triathlon knee. You can look up the company. I won't name company names. So that knee's been on the market for 8 years. It's been implanted worldwide for a long time. They made a lot of money off of it, and they just decided to come up with a new marketing campaign. That's all that is, folks. The get around, go around knee. It's another company that got FDA approval to market their knee as a 30-year knee. They actually got the FDA to give them permission to market a knee as a 30-year knee. Now, I think that's absolutely insane, personally, if I'm the company. They must have some pretty good lawyers, because when that knee fails at 5 years, I can just smell the sharks in the water coming after the company. Well, you said this knee is going to last me 30 years. It only lasted me 5. I mean, that's just, and they did that based upon wear simulator data in a laboratory, and the FDA gave them approval. I honestly can't believe that occurred, but whatever. So remember, these companies are vying for your business. There are nearly 1 million hip and knee replacements done in this country alone, let alone worldwide. They've got the same technology in France and England and Australia and New Zealand and Sweden and all these other advanced countries. Okay, even China's implanting high-end devices, North Korea, South Korea, Japan. I mean, every civilized country is doing this surgery. This is a major, major, major play for your business. And it's not just the implant companies, it's the pharmaceutical companies, all these folks that are putting commercials about people sitting in a bathtub holding hands, staring at the mountains. Okay, I won't go any further than that. They want your business. They are for-profit corporations. They are marketing to you just like Ford and Chevrolet are, and they're in direct competition with one another. I will stand here and tell you, since I don't take a dime from any of them, there are specific situations where one company's implant may be better than another for certain patients, and I won't bore you with the details. One of the situations would be considerations over nickel allergy, if that's actually a real thing, which we still haven't scientifically proven. Okay? But that being said, if your surgeon knows what he or she is doing and puts in one of the 5 major corporations' knees or hips, the chances are you're going to do very, very well. There's probably not an appreciable clinical difference between any one of these implants in your body. What's important is if your surgeon's honest with you about why they use the device they use, if you bother to ask that question. Are they financially motivated to do so? They have to legally and ethically declare that to you. Or are they most comfortable with that implant? I tell you the reason I use the implant I use, it's what I grew up on. That's what I know. I know how that knee is supposed to feel. Sometimes Heath will stand there and he'll look at me and he'll go, "What are you thinking?" I'm like, "I don't know, but it feels right." I mean, that's just how it is. You get comfortable with it. It's just like anything else. You get comfortable with a particular golf club. Some people buy a whole new set of golf clubs, but they keep their old 7-iron. Anybody that's a Curb Your Enthusiasm fan, you pull a 5-wood out of a casket, right? If anyone's seen that episode. So we get comfortable with what we use. So I like this implant because I know how it's supposed to feel. I know my options with it, and I'm going to give you your best chance for a great outcome. From disabled to able-bodied, if you put in the work within a relatively short period of time. And it's hard to get people to understand that arthritis builds for 3 or 4 years. And it's slow, as I mentioned way back at the beginning of this talk, because like my wife's probably saying, wrap it up. You talk too darn much about this stuff. But we took you from somebody who had a slow stepwise decline in their function over a period of time where it's so slow you don't even pay attention to it until one day it hits you, I got old. Right? You just can't do the things you used to do. And mind and the rest of your body are saying go, 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 but your hip or your knee saying no, no, no. We take you from that, which took years to get to that point, and we take you within about 8 weeks back to an able-bodied person, or at least so much more functional than you were that you will rather soon forget the place you've been. And I don't mean to imply that a hip or knee replacement recovery is 8 weeks long. It's actually 6 to 12 months long. And those of you that have had a joint replacement can attest to the fact what's important about your joint replacement is the day you wake up and you forget you had it done. It's become one with you and you move on.